Good morning. Welcome to Epidemiology of HIV AIDS and Hepatitis B among African Immigrants, Current Status, Barriers, and Challenges. This is the first webinar in our series focused on African Immigrants, HIV, and Hepatitis B, which we are launching this month as a part of Hepatitis Awareness Month. During the presentation, all participants will be in a listen-only mode. You may enter questions throughout the webinar by using the chat feature located in the lower left corner of your screen. Questions will be answered at the end of all three presentations. Please make questions clear and concise. As a reminder, this webinar is being recorded. This webinar is sponsored by the Multicultural AIDS Coalition, the oldest minority AIDS service organization in New England, dedicated to mobilizing communities of color to end the HIV/AIDS epidemic. The Multicultural AIDS Coalition's Cultural Competency Series is supported by the New England AIDS Education and Training Center, NEATEC, Minority AIDS Initiative, through a grant from the Health Resources and Services Administration, HRSA. Continuing education units are offered for nurses and social workers. To receive continuing education units for this program, participants must 1. Read the learning objectives and faculty disclosures, 2. Attend the program in its entirety, 3. Answer any polling questions presented, and 4. Complete an evaluation form. The certificate will be emailed to participants within 4 weeks. The speakers and planning committee members for this course have been asked to disclose any significant relationships with commercial entities that are either providing financial support for this program or whose products or services are mentioned during their presentations. There are no disclosures to report by speakers and planning committee members. The training objectives are provided. This webinar is designed to be interactive. Participants are encouraged to ask questions throughout the presentation via the chat box located in the lower left corner of your screen. Questions will be answered at the end of all three presentations. Please make questions clear and concise. There will also be polling questions so that faculty can build on your knowledge and experiences. Please participate by choosing an answer when the polling questions are displayed. Immediately at the end of the training, you will receive the evaluation. Keep your web browser window open, and in place of the webinar screen, a pop-up window will appear with questions. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Now, I will invite Chioma Anaji, Program Director at the Multicultural AIDS Coalition, Africans for Improved Access Program, to get us started.
Thank you. Before we have our first presenter, we would like to get a sense of who is participating on the webinar. So as you can see, our first polling question is asking for you to provide your primary service. Where do you provide your primary service? Is it at a clinical organization, a non-clinical organization such as a CBO, a faith-based organization, an academic institution, or other? Please select the appropriate choice and click Submit. So as we can see that a significant number of folks are representing other organizations, and then our next big group are non-clinical organizations as community-based organizations. So thank you for doing that polling question. We have one more polling question to get a sense of who's on the webinar. So please answer, what is your primary role? Are you an MDPA? Are you a nurse, mental health professional, social worker, community health worker, administrator, or other? Again, please select the appropriate choice and click Submit. Thank you again and again. We see that we have other professionals on the call, and we have our second group would be nurses and community health workers. So I would like to, on behalf of the planning community, to welcome you again to the webinar, and now I would turn it back over to our moderator, who will introduce the first presenter.
Now we'll have our first presenter, Dr. Perumalswami. She is an assistant professor of medicine in the Division of Liver Diseases at the Mount Sinai School of Medicine. Her research program focuses on community outreach for hepatitis B and C screening and linking patients to care. She is an investigator for many ongoing clinical trials evaluating the safety and efficacy of new antiviral treatments for chronic hepatitis B and C. Lastly, she is UNOS certified liver transplant physician and is board certified in internal medicine and gastroenterology.
Thank you for that introduction, Keith. And I just want to start by saying thank you to the Multicultural AIDS Coalition, in particular to Chioma Naji, for inviting us to speak today and organizing a really great webinar series. So I'll be speaking today on hepatitis B screening and linkage to care in African immigrants, and be highlighting some of the epidemiological factors here. So we know that the global burden of hepatitis B represents a major public health burden, particularly because over 300 million persons are infected with chronic hepatitis B. In the United States, we see approximately anywhere from 800,000 to 1.4 million people, at least in the United States, that are chronically infected with hepatitis B virus. And what you see here is that there is a geographic distribution with respect to hepatitis B surface antigen prevalence, which is the marker for how we screen patients and diagnose them for hepatitis B. And what you'll see here is that areas highlighted in red and that deep orange have the higher prevalence of hepatitis B surface antigen, greater than or equal to 5 to 7% in those in the deep orange colors in sub-Saharan Africa and parts of East Asia, and then greater than or equal to 8% in parts of West and other parts of sub-Saharan Africa. And what we know is that certainly one of the chronic sequelae that can happen from infection with chronic hepatitis B is the risk of liver cancer. So here what you see is data that was published in the British Journal of Cancer back in 2012, looking at the distribution of males compared to females with respect to major cancer burden within both of these genders. What we certainly see here is that those areas in which you see highlighted by green represent liver cancer, and what makes hepatitis B also unique compared to other chronic liver diseases is that the risk of liver cancer certainly increases with cirrhosis, but still exists in patients who don't have advanced liver disease or cirrhosis as well. We do certainly have a highly effective vaccine for hepatitis B, and there have been substantial efforts by Gavi and others to try to catch up vaccination programs within a number of nations, including sub-Saharan and West African nations. One of the significant public health issues that we struggle with here in the United States is that viral hepatitis, both B and C, but because we're talking about B, this is where we're going to focus today, is severely underdiagnosed in the United States. It's estimated that well over 50% of people with chronic hepatitis B infection have not yet been diagnosed of their chronic disease. And this is in kind of stark contrast to what we see with HIV, in which it's estimated that around 20% of persons with HIV have not yet been diagnosed. And I think one of the major challenges remains is how do we target patients for testing and screening for hepatitis B in order to get them diagnosed, and then, of course, doing the very important work of transitioning them or linking them to care. And one of the main issues here is that, as we know, more than 50% of patients with chronic hepatitis B infection will have no symptoms at all until they develop, unfortunately, a very late complication or advanced complication from liver disease, such as liver cancer, liver failure, or need for liver transplant. When we think about the U.S. response to HIV and compare it to viral hepatitis epidemics, we see that there is a bit of disparity in terms of the prevalence of infection that we see and the amount of funding that has been appropriated for care, prevention, and research-related activities for both viral hepatitis B and C compared to HIV. So this is definitely an area with unmet need to try to really establish more resources for us to do more important work around hepatitis B and C in the United States. Because we do have a highly effective vaccine, and with implementation of universal vaccination programs in the United States, we have certainly seen a decline in the estimated new cases of hepatitis B infection with implementing these hepatitis B vaccination approaches that are often perinatal programs. So since 1991, when we implemented these programs, we have seen a dramatic decline in the estimated new cases of hepatitis B infection. The thing to remember here is that we certainly have a number of people and communities that immigrate from places in which universal hepatitis B vaccination programs have not yet been established, particularly in the perinatal setting, and a number of people, even in this country, were born well before 1991, certainly putting them at risk for potential infection or having the disease and needing to be screened. And so when we look at who are our candidates for hepatitis B screening, we had prior recommendations that were more recently updated in 2008, and then through a couple of more MMWR reports since that time, there have been the addition of some other at-risk groups. The thing I wanted to highlight here, because our focus really is in looking at African immigrants and chronic Hep B, is to really highlight the addition in 2008 in which there was a recommendation put forth to really offer screening for hepatitis B in persons born in high endemic areas. So if you think back to that first geographic slide that I showed, anybody born in a country in which the estimated prevalence of hepatitis B surface antigen is greater than or equal to 2% is recommended to be tested. Other groups certainly include U.S.-born persons not vaccinated as infants whose primary family members were born in high endemic areas, so anybody who had a parent who originated from one of those high prevalence countries greater than or equal to 8%, men have sex with men, persons needing cytotoxic or immunosuppression therapy, persons who have ever injected drugs, and individuals with chronically elevated ALT and AST of unknown etiology. As I mentioned, through additional MMWR reports, there also have been the addition of nursing home residents as well to this recommendation. So what we do know in the United States is that the number of African immigrants in the United States has decreased dramatically from 1960 to 2007. It's by many standards considered the fastest growing immigrant population. Immigration increased 184% between 1990 to 1990 and 212% between 1990 and 2000. It's estimated that more than 1.7 million African immigrants live in the United States, and more than 200,000 people of African origin live in the New York, New Jersey area. So what I'm going to take you through now is some data that's been published by a number of different groups that have really done some targeted hepatitis B screening and linkage to care programs. And I think that certainly this has been a growing movement. There have been a number of different communities now throughout the United States who are really trying to focus on African immigrants with respect to hepatitis B screening and linkage to care. So this was data that was published in May of 2014 from the folks at the CDC who had funded a hepatitis B and screening and linkage to care program over a 2-year period between 2012 and 2014. This is data from 3 of the sites that were funded, including a site here in New York City, Minneapolis, St. Paul, and San Diego, California. And so what you see here is that the total number of persons that were tested, and I should say that the testing here was not exclusive to African communities in this data. I will show you some data that's more specific to African communities. But this program was really designed to try to target persons originating from intermediate and high prevalence hepatitis B surface antigen prevalence countries. And so really large populations of Asians and Africans were included in these results. So a total of 4,727 patients were tested, of which 6.6% or 310 individuals were tested hepatitis B surface antigen positive. The vast majority of positive persons were successfully reached with the results, 94%, and counseled regarding the results and given referrals for further follow-up care. And about 66% in total attended their first medical visit. So what they really highlighted here in their MMWR communication is that in cities with large populations of Asians and Africans, community-based efforts to screen foreign-born persons from countries with intermediate high hepatitis B prevalence can identify substantial numbers of persons with hepatitis B infection. And persons who test hepatitis B surface antigen can be successfully informed, counseled, and referred to medical care. What they also noted was that culturally and linguistically specific approaches were necessary in all phases of the initiative, from planning, implementation, screening, counseling of test results, and linkage to care. And finally, outreach, counseling, and patient navigation activities in this population require intensive effort and use of human resources. So I wanted to now highlight a couple of different programs in which there's been more targeted screening. One certainly has been in the Somali immigrant population in Minnesota. This was published by Shire and colleagues back in 2012, looking at the number of hepatitis B infection in Somali versus non-Somali groups that were tested. And what you certainly see is with respect to hepatitis B surface antigen, this is reported as frequency per 1,000. Highest frequency we're seeing in the age groups, certainly in the 50 to 60 range, and consistently men seem to test at a higher rate of being positive compared to women. There's one outlier there on the left in the Somali group in the age bracket 61 to 70-year-olds. And in non-Somali groups, you'll see that the frequency of hepatitis B surface antigen testing is much lower compared to the Somali group. And they also looked at hepatitis B core antibody as a marker for exposure and did the same kind of comparison between Somali versus non-Somali groups screened. And what you see is that the exposure frequency as defined by presence of core antibody seems to increase pretty sequentially with age in the Somali group as compared to the non-Somalis. I will share a little bit about the data that we've collected here in New York City. So in New York City, we have a very active city Department of Health that actually reports passive surveillance reporting of hepatitis B, and they break this down in New York City by zip code. So this is data from 2006 to 2007. So the darker areas that are shaded here have higher prevalence, higher reports of hepatitis B surface antigen testing being positive. And what you notice here in New York is that actually the highest concentration of reports come from in and around the major 3 Chinatown areas in Flushing, Queens, Sunset Park, and Lower Manhattan. So certainly what we've embarked on here in New York City has been a partnership between an academic institution and community-based organizations and community gatekeepers. And we also engage culturally targeted patient navigators to provide free education, free testing, and linkage to care. And the results from our program over the first 955 persons that were tested, total of 11.3% or 108 persons tested positive for hepatitis B surface antigen. Men had a surface antigen detection rate of around 13% compared to women 5.6%, and that was a significant difference. When we looked at our data regarding exposure, a total of 74% of this close to 1,000 patient cohort had evidence of core antibodies. So 75% of people had been evidence of prior exposure infection. And again, you had a little bit of a difference between men at 78% and women at 61%. And in terms of the other test results, about 15% had all their hepatitis B serologies negative. And what's a little bit unique in our testing program is that we test not only for surface antigen, but surface antibody and core antibody. So all negative meant that you had an opportunity for prevention through a vaccination. 10.5% had evidence of prior hepatitis B vaccination, meaning they only had surface antibody that was positive. and about 14% had core antibody positive alone. And for the sake of time, we'll just say that the highlights in terms of what risk factors predicted testing positive for hepatitis B infection in our cohort, again, 1,000 patients, was male gender, younger age, and having a family history of liver disease or mother with hepatitis. And when we looked at what predicted exposure, again, in this section, a little bit older age, male gender, and not having had a blood transfusion actually seemed to be protective, which was a little bit counterintuitive in our series. In terms of our linkage to care rate, 93% were successfully notified, 83% attended follow-up visits, and out of the first 8 patients recommended to begin treatment, 6 have begun. So in our cohort here in New York City, patients were primarily from West Africa, limiting the generalizability of this data potentially. And further research is really needed in order to elucidate risk factors for hepatitis B transmission and even exposure. And a larger sample size will hopefully help us better define the prevalence and risk factors in this community. So the rate, based on a lot of the data that we've seen here, the rate of chronic hepatitis B in Africans in New York City and other places in the country have shown to be consistent with rates of chronic hepatitis B infection in African nations, much higher than the baseline U.S. non-African population here in the United States. And what we've seen through a number of these studies is that culturally targeted patient navigation certainly results in higher rates of screening and follow-up. In terms of future directions, we certainly, many different groups throughout the country are really trying to do the good work of spreading awareness around hepatitis B and its sequelae in African-born communities. I think we need more work with respect to elucidating more modes of transmission and really identifying barriers to and facilitating factors for hepatitis B screening is going to be very important in order for us to understand how to better target this community and get more people tested and linked to care appropriately. So I'm going to end with 2 polling questions here. The first is, hepatitis B can be transmitted from infected mothers to infants at the time of birth or from family members to infant in early childhood. True or false? And let's see what the response was. And we're still, looks like we have about 40 responses in so far. Give you guys another 10 seconds. Okay, so true, and true was the correct answer. Let's go to our last polling question for this first series. Targeting hepatitis B screening in persons originating from countries with low hepatitis B surface antigen, meaning less than 2% Hep B surface antigen prevalence is recommended currently. We have about 35 responses in. Give folks a couple more seconds. And so the correct answer was false, and that's what the majority of folks answered here. I'd like to thank the participants and, again, the organizers for inviting me to speak today. Thank you.
Our next presenter is Dr. Kerani. She is an acting assistant professor in the Division of Allergy and Infectious Disease, Department of Medicine, with an adjunct appointment in the Department of Epidemiology at the University of Washington. Before joining the University of Washington, she was an epidemiologist in the HIV STD program of Public Health, Seattle and King County, where she is currently affiliated. Her research interests focus on infectious diseases, including public health interventions to reduce sexually transmitted infections and the epidemiology of HIV and tuberculosis among African immigrants and refugees in the U.S.
Thank you, Keith, and good morning to everyone. Thank you for joining the webinar. For some of us on the West Coast, it's pretty early, so a big shout out to anyone else who's up early this morning. I am going to be talking about the epidemiology of HIV and AIDS among African immigrants this morning. And just to start off, I have a few bullets with an overview of my talk this morning. I'm going to highlight very briefly a few things about African immigration to the U.S. Then I'll talk a little bit about national HIV surveillance in the U.S. And then I'll take you on a very brisk walk through the epidemiology of HIV in the African population here in the U.S., including some information about what we know about reported cases and the number of cases, HIV transmission category that's most often reported for African immigrants, and also trends and patterns with late diagnosis in this population. And I'll end with a few slides looking at projected trends in HIV in the African immigrant community in the U.S. So to start off with, I have my very first polling question, which is, hopefully you were all awake during Dr. Perumalswami's presentation, and you can answer this question. How much did the U.S. Black African immigrant population increase between 1990 and 2013? Please submit your answer. We have about 40 answers so far. I'll give people a few more seconds to respond. Okay, so the most frequently chosen answer was 110%. And the correct answer is actually 645% between 1990 and 2013. The figure on this next slide shows the number of Black African immigrants living in the U.S. between 1980, it says 2009 on the slide, but it's actually 2013. And so you can see this huge increase over time with an especially large increase from 2000 to 2013. But in 1980, there were only 68,000 African immigrants living in the United States, according to census data, and that increased to 1.4 million in 2013. So there really has been a very large increase in the population over the past 20 or 30 years. And so a lot of the population that's here now has arrived fairly recently. And according to the Migration Policy Institute, which has analyzed census data several times over the past few years, 36% of the African immigrant population in the U.S. in 2013 had arrived since 2006. Also, the map on the bottom of this slide shows the metropolitan statistical areas where the African immigrant population is concentrated. And you can see that there are particular areas in the U.S. with very large populations, with the circles, in the size of the circles indicating the number or the size of the population in each place. And that's why you hear some of these places coming up again and again in presentations about African immigrants. It's because there are large populations there. And as an example, in my second bullet on the slide, you'll see that the New York, Washington, D.C., and Atlanta metropolitan statistical areas accounted for 26% of the overall African immigrant population in the U.S. during that time period. So because the population is very concentrated in some places, I think that sometimes when we're looking at national statistics or national data, it's overlooked because it's not thought of as being a countrywide or national problem. Next, I'm going to move on and talk briefly about U.S. HIV surveillance. Just to give you a brief overview for people who aren't familiar with the case reporting system in the U.S., each newly diagnosed HIV case in this country is reportable to your local or state health department. Those health departments transmit data about each case to the Centers for Disease Control and Prevention. However, country of origin, hereafter abbreviated COO, is not consistently collected, and it's not required for transmission to the CDC. So there are a set of specific data elements about each case that the CDC requires in order for it to officially count the case as coming from a given health jurisdiction. But country of origin is not one of those that's required. And so as you can imagine, this leaves us with a lot of questions related to missing data, because country of origin is often not collected or submitted or presented. So two analyses that were done recently of national HIV surveillance data, which I'll talk a little bit more about in a few slides. In both of those analyses, they found that almost 20% of the cases were missing country of origin. And so that leaves us with not good data about what's happening on a national level with HIV in African immigrants. So now I'm going to move along and talk a little bit more about the epidemiology of HIV in African immigrants and what we do know about reported cases in the U.S. These data come from a study done by Anna Satcher-Johnson and her colleagues at the CDC, which was published in 2010. And in this analysis, the authors looked at Black cases who were reported from 33 states for the period 2001 to 2007. And I just want to focus on the second bullet here. Of all of the cases that were reported who had a known country of origin, almost 5% of them occurred among African immigrants. In contrast, the African immigrant population in the U.S. accounts for less than 1% of the total population in the U.S. In fact, it counts for less than 0.5%. And so we see really a disproportionate share of cases in African immigrants. Another similar study that was done with cases of HIV, regardless of race and ethnicity, was done for a later period of time, from 2007 to 2010, and included data from 46 states. And in this analysis, they found that 2.3% of all of the cases with known country of origin were among African immigrants. And among women, when you looked only at cases among women, African women represented the highest number of foreign-born cases among women. They accounted for 30% of the foreign-born cases. And 5.7% of all of the women reported with HIV and a known country of origin in the U.S. And on the last bullet, also concerning, almost 3/4 of the cases among people who are born outside of the U.S. who were infected perinatally or were pediatric HIV cases occurred among African immigrants. I'm going to skip this slide and move on to some local data from here in King County. King County is where I'm located. It includes the city of Seattle. And if you look at the figure on the right side of the slide, it shows what proportion or percent of the foreign-born Black population here in King County, which is primarily African, is HIV infected as of 2013. So we believe about 1.7% of the population here in our county is infected with HIV, and you can see how that compares with other population groups, excluding men who have sex with men. And for the period 2008 to 2013, foreign-born Blacks here in our county accounted for 11% of all of the new HIV cases that were reported, and account for less than 1% of the population here in King County. We see similar data from the state of Minnesota. Again, the figure on the right shows diagnoses per 100,000 population, and it compares the African-born diagnoses versus for the state overall. And you can see that among African immigrants, there were 54 diagnoses per 100,000 population, compared to 5.7 for the overall state of Minnesota population. And these data come from the Minnesota HIV/AIDS epidemiology profile, and they have African-born data broken out separately. And in 2013, there in Minnesota, the African immigrants and refugees accounted for 14% of the new HIV diagnoses that were reported, but again, accounted for only 1% of the state population. Finally, moving to a larger metropolitan area, I know it's easy for people to maybe write off Seattle and the whole state of Minnesota because we have smaller HIV epidemics and a different population mix than some of the larger urban areas. But these data come from colleagues at the Department of Health and Mental Hygiene in New York City, and this slide shows the annual number of HIV diagnoses per 100,000 population for 2006 to 2010 by region of origin in New York City. And again, you can see this rate among African immigrants is much higher, almost 3 times higher than most of the other population groups shown on the slide. Moving along to transmission category is the route through which we think that people acquired their HIV infection. This slide is a slide taken from the National Surveillance slide set that's available on the CDC website, and it shows transmission category for all cases reported in 2013. You can see from the big orange arrow on the left side of the slide pointing at the pink shaded areas that about 25% of the cases overall were thought to have acquired their HIV infection through heterosexual contact. However, the patterns we see in African immigrants are very different, and so this brings me to my next polling question, which is, in the national data that I mentioned earlier, including 46 states from 2007 to 2010, what proportion of African-born HIV cases were attributed to heterosexual sex in that analysis? So please choose your answer. Okay, there's still a few answers coming in. I'm going to close the poll now. The most frequently chosen answer was C, 74%, and that is correct. This next figure shows the proportion of cases reported in each of these areas with heterosexual contact as their transmission category by region of origin, but unfortunately I didn't have US-born numbers for some of these areas, but you can see that across the board, both in the national data that have been looked at and from other local areas, that a large proportion of African immigrant cases are thought to have acquired HIV through heterosexual contact. King County data is a little bit of an outlier here, primarily because many of our cases are categorized as having no identifiable risk, but we do believe that many of those cases acquired HIV through heterosexual contact. The next slide is another CDC slide that shows the difference in the pattern of transmission categories by gender, and I really want to focus on the left side of this slide, which I'm sorry is a little bit blurry, but it shows transmission categories for all men reported with HIV in the US in 2013. And as you can see from the yellow shaded area here, 81% of men from 2013 who were reported with HIV had the transmission category of male-to-male sexual contact. So that's what we see in the country overall. This next slide I took directly from the Minnesota HIV/AIDS epidemiologic profile because I thought it was a great contrast to that CDC slide. And this shows the transmission category by gender for African-born cases reported to the state of Minnesota from 2011 to 2013. And again, if you look at the figure on the left, among males in Minnesota, they saw that 86% of the male cases were thought to have acquired HIV through heterosexual contact. This is not to say that heterosexual contact is the only way that African immigrants and refugees acquire HIV, because certainly there are some men who have sex with men in this population. And if you look at different areas around the U.S., I think you see a pattern similar to this among men, where the majority of men probably acquired HIV heterosexually, but there are also some men who are acquiring it through male-to-male sexual contact. Now I'd like to talk briefly about late diagnosis in the African immigrant population. Late diagnosis is a problem because when people are infected longer without being treated, it potentially gives them, A, more time to infect other people when they're not aware that they're infected, but it also can lead to pretty severe illness and disability in people if they're not tested and caught early enough. And so I just wanted to highlight this a little because I don't have a lot of time, but this slide shows the proportion of all cases in the U.S. that were diagnosed with an HIV and AIDS diagnosis concurrently in 2012. So these are people who met the criteria for having AIDS at the time that they found out that they have HIV. And in 2012, for the country overall, that figure was 24%. But when we look at this issue in African immigrants, you see a little bit of a different pattern. So this table is a little bit busy. The first column shows the source of the data for all of these numbers, and then the next column is the study period, and then how the population is defined, and how the late diagnosis was defined for each of these analyses. But you can see in the last column on the figure the proportion of cases in all of these areas that met criteria for having a late diagnosis. And that hovers right around 40% for African immigrants. And I think it's fascinating, actually, that it's so similar across these different areas. One thing that I will note is that in studies that have looked at people who are born outside the U.S. generally, they tend to be diagnosed later, probably for a variety of reasons. And so this may not be unusual for immigrants as a whole, but it's certainly something that we need to draw attention to. Now I'm going to move on to projected trends in HIV in African immigrants. And because of some of the issues with the data that I've talked about previously, we don't really have a good sense of how the numbers are changing over time or how the epidemiology of HIV in African immigrants is changing, especially at a national level over time. Many of you are aware that in 2010, a ban on people with HIV entering the country was lifted in the U.S. And I just want to present some data that were developed around that time to project how many people would enter the U.S. who were HIV infected after the end of the immigration ban. So just a little background on the immigration ban. It was in place in the U.S. through 2010. It limited the entry into the U.S. of people who are living with HIV. In some cases, that depended on their self-disclosure of their HIV positive status. Many visa types required HIV testing either in a person's country of origin or here in the U.S., and waivers were available for some people who were living with HIV. As I mentioned, the CDC developed data at the time that they were considering, the government was considering lifting the ban, and based on data for the number of immigrants entering the country each year and the prevalence of HIV in all of the countries or the regions of the world that the immigrants come to the U.S. from, they developed predictions of how many people would enter the U.S. each year with HIV infection. And for the African immigrant population, they estimated that that number would be 1,735. So on this slide, I started out with an estimate of the number of people who were reported nationally between 2007 and 2010. That's the 3,656 number that you see here. And then I added 1,735 for each year between 2010 and 2020. And that resulted in the yellow line that you see on the slide. So that brings us to over 21,000 cases, potentially, in 2020. One of the issues with this method is that it doesn't take into account the possibility of onward transmission, or people who are living here with HIV and unaware of their HIV infection status or aware, potentially transmitting HIV to others. And so the CDC also developed some numbers for what they expected the rate of onward transmission would be. The yellow line on this slide shows the same line that you saw in the last one, where we end in 2020 with about 21,000 cases. But if you use their lower estimate for what they thought would be the rate of onward transmission, or 1.5% per year, that brings us up to 22,800 cases in 2020. And if you use their upper bound of onward transmission, that brings us to 27,000 cases in 2020. And it's hard to say what is right or whether the onward transmission rate will fall somewhere in the middle here, but given what we know about late diagnosis in the African immigrant community and the possibility for people to be unaware of their infection for longer than others, I would guess that the onward transmission rate will be a little bit on the higher end. But that's speculation at this point, and because we still don't have really good data to track this over time, it may remain speculation, unfortunately. I'm going to skip this slide. I'd just like to summarize with a few points. Definitely, we have challenges in the U.S. in terms of looking at national data because of the issue around country of origin. We do know that African immigrants are disproportionately affected by HIV in the U.S., and most, but probably not all, well, definitely not all, African immigrants acquire HIV heterosexually. We think that late diagnosis is more common in the African immigrant population than US-born people with HIV, and the number of HIV-infected African immigrants will probably continue to get larger as the population grows. And that's part of the reason that I started out with the slides about the growth in the population. There's no reason to expect that the population will stop growing, and it may, in fact, increase more quickly than those estimates from the CDC expected. And so to close, we really need better testing and outreach programs in order to find people and bring them into care earlier. And we need to do a better job with our data and capturing this issue on a national level. I'd like to thank you for your time. I do work for our local health department in addition to the University of Washington, and I'm interested in getting more data and knowing what's out there. I did find data from a few other health departments on their African immigrant populations, but if there are other places out there that you are aware of that look at this locally, I would love to have that information, and please send me an email. Thank you very much, and thanks to the webinar organizers for inviting me to speak today.
Our last presenter is Ms. Martin, who is the project manager for cultural competence at the Adventist Healthcare Center for Health Equity and Wellness. In this role, she manages the activities of the center's project Beat It, Becoming Empowered Africans Through Improved Treatment of Type 2 Diabetes, Hepatitis B, and HIV/AIDS. Ms. Martin's health equity experience includes planning and evaluating health programs for chronic and infectious diseases in urban communities, as well as a voluntary full-time 18-month commitment as a community health worker assisting diverse and underserved persons in obtaining public health services. She earned her master's in public health and behavioral science and health education from St. Louis University in St. Louis, Missouri, and a bachelor's in biochemistry from Brigham Young University in Provo, Utah.
Good morning. Thank you very much for that introduction, Keith. And thank you to my good colleagues for the great work that they are doing. I'm appreciative of the opportunity to be on this webinar, especially as it is timely for the month of National Hepatitis Awareness, preceding the month of National HIV/AIDS Testing Day, and timely for the moment that African health is having in the public health arena as we look at Ebola and other concerns related to African immigrants and those of African origin. And so as we talk about this topic, specifically as I focus on barriers and challenges, I hope that the information will be applicable beyond just infectious diseases, HIV and AIDS, and hepatitis B, but also speaking to the needs of African immigrants as far as all of their health concerns that can be addressed. To provide you with a bit of background about my organization, Adventist Healthcare is based just outside of Washington, D.C. in Montgomery County, which is northwest to Washington, D.C. in Gaithersburg, Maryland. We are a nonprofit, faith-based system that is focused on addressing the needs of vulnerable communities, and African immigrants are certainly a part of that population. We have 5 focus areas that hopefully address the needs of our vulnerable populations and work at achieving health equity, as we have community health outreach events, physically going out to neighborhoods, going out to communities, and touching bases with the populations we serve. Community benefit, providing assistance to communities to support the work that they already have going in place. Health ministries, to support the mission that the Adventist Healthcare Church has in health and wellness. Our health programs delivery is a partnership with our acute care hospitals to take the treatment that they provide as inpatient to an outpatient setting and continuing to provide health and wellness programs. And then research and education, which allows us to take the data that we receive through identifying the needs of our communities and working to address and formulate programs that will allow us to reduce the disparities and achieve health equity with our vulnerable communities. Here in the Washington, D.C. area, we are the second highest population of African immigrants that come to the U.S. About 11% of the total immigrant population here in the diverse area of Washington, D.C. are African-born residents, 60% of who reside in Montgomery and Prince George's counties, the 2 counties that border Washington, D.C. on the Maryland side, and are also the catchment areas for Adventist healthcare. Generally speaking, African immigrants are college educated. They're often coming to pursue multiple degrees, their second or third degree. They tend to do very well, socially, economically speaking, but of course there are some challenges that are unique to the cultural heritage that African immigrants are bringing with them that I'll discuss in greater detail. Specifically looking at Montgomery County, where Adventist Healthcare is based, African immigrants in 2010 came together with the U.S. Census and decided that they wanted to look more and be identified as more than just Black or African American, but specifically wanted to look at some data around countries of origin. And so this graph dialogues outlines the specific countries of origin, the top countries of origin represented here in the county. As a daughter of African immigrants, specifically Nigerian immigrants, a bit disappointed that we're only 10%. Nevertheless, we have a great West African representation here in the Montgomery County region. This brings me to my first polling question that will be true or false, an individual's past experiences, culture, and education can influence their willingness to engage in healthcare services, including HIV and AIDS and hepatitis B. You got a steady increase of participants. I'll give you a couple more seconds to put forth your answers. And overwhelmingly, unanimously rather, all of you say true, and that indeed is the case. To give us a bit more background about this topic, which is an introduction to the focus of my presentation, there is a video that I will display. Our organization, the Adventist Center for Health Equity and Wellness, had the opportunity to be featured in an international news story last year for the work that we're doing around African immigrant health. And so without further ado, I'll let this YouTube video speak to the barriers and the challenges that come with African immigrants as they seek health care in the U.S.
Washington, D.C. lies a health clinic on a mission to make sure newly arrived African migrants get the care they need. South African-born Toko Moffat treats HIV patients here, but says a culture of silence among Africans makes that mission hard.
Actually, mentioning the word HIV, people will call it names. For instance, in South Africa, they call it like, they say and it's a Zulu name, amagama amathathu, meaning 3 names, HIV. So if a person says, I have, such and such a person has amagama amathathu, meaning 3 names, everybody knows that it's HIV. So there's still that stigma, and people don't want to come and be tested.
Toko Moffat has dedicated herself to the health of African migrants and refugees in the US for 30 years, but she's quiet about her own personal story of survival and migration. She's the widow of a well-known political prisoner, George Moffat, who was sentenced to 15 years in Robben Island prison when Nelson Mandela was held at the age of 17.
We decided to skip. When we left, we went to Botswana, and that time our son was like 2 years, no, he was like 17 months, because he turned 2 in Botswana. And then when we were in Botswana, because refugees were being persecuted as well, some of them were killed in Botswana, so we left and came to the US.
It's a story that resonates with many African immigrants living in this particular county of Maryland, where 60% of the black population is African-born. Many have fled war and instability to make a new life for themselves here, but their health issues are very different from those facing African Americans, according to managers of a health program directly targeting new arrivals.
The challenges that African immigrants face are typically coming to the United States and being isolated, meaning they don't understand the language, they may not understand how to access health care, so where do I go to seek help?
So I would like to go over with you
Making sure patients take their medicine and follow treatment plans is a daily challenge for diabetes practitioner Michelle McBride. She says it was only when she realized her patients had very different cultural and dietary backgrounds that she became more sensitive to their needs.
It helps me be more effective to them, and and I think that they get a sense that I really care about the fact that they have a different diet, and that I'm more sensitive to that, and that we can work in that way to, just to help manage their diabetes better.
But very often a lack of insurance and poor finances present the biggest burden of all to African patients in the United States.
As you take on different occupations, different work to supply for your family's needs here, as well as sending those funds back home. That tends to be a huge issue in the African migrant community, that you're not just taking care of the family and your resources here, but you're often caring for a family back at home.
The fact that U.S. healthcare providers have become increasingly aware of the health problems faced by African migrants shows just how acute the problem of accessing healthcare in this country has been for that particular community. But doctors and clinicians say with additional resources, they can treat them far more effectively and hopefully deepen the level of trust. Nina Marapot, CCTV in Washington.
So that video speaks to challenges that African immigrants face when they come to the U.S., as well as some challenges that their providers face. And that's a great segue into the remainder of my presentation. Of course, this slide does not speak to every single challenge that the African immigrant patient may face in the U.S., but it speaks to some of the primary challenges that were referenced in the video, as well as that some of you may have encountered in your settings with your African immigrant patients. Negative encounters, be they here in the U.S. or back home in their native land, can definitely impact health-seeking behavior and whether I'm willing and able to negotiate and engage in the healthcare system while I'm here and in need of services. Regarding immigrant status, are you eligible to receive healthcare as an African immigrant? Are your papers current such that you don't have concerns about seeking services from a public facility, from a government entity? Or even if they are current, perhaps you've got a lot of challenges that you feel might make you vulnerable to having your immigrant status questioned. Regarding confidentiality, often what is said in many African communities is that confidentiality doesn't even exist. It's not even a word, because in many cases, thinking of the circumstances of your homeland, confidentiality is something that's almost non-existent, in that perhaps you can go and see the doctor in the morning and by dinner time, the whole neighborhood's aware that you had an appointment and the nature of that appointment. And it's not necessarily with malicious intent, but just the nature of society that sometimes things that should be kept in confidence are not. And so when you're coming and speaking of confidence around very sensitive issues such as infectious diseases, HIV and AIDS, hepatitis B, that definitely can provide a challenge to African immigrants as far as seeking health behaviors here in the U.S. Regarding religious beliefs, perhaps I have beliefs that conflict in some way with the prescribed medication or prescribed treatment that you're offering. Perhaps I fast often, but the medications you are asking me to adhere to are going to conflict with that because I need to take them at a certain time and on a full diet. So how do I balance my religion and the treatment plan that you're offering me? One thing that was spoken to very well by Toko Mofat in the video previously shown is stigma, the idea that having a disease, and especially an infectious disease, HIV and AIDS, one that has really had a detrimental effect on the continent. To say that is quite the understatement, but HIV and AIDS and any disease, but especially infectious diseases, have such a harsh stigma that it's very hard for people to even talk about, much less participate in health-seeking behaviors around that as an African immigrant. And so stigma, as one of my colleagues often says, is something that can kill because it often is so strong that people won't even seek health, won't even seek treatment. And so stigma is a very significant barrier as far as African immigrant patients are concerned coming here in the U.S. Similarly, lack of services and resources to support them that are culturally competent, that are culturally appropriate for their needs. Often, people continue to bring and participate in their diets and their cultures and their traditions. And if you're providing care or treatment plans that are in conflict with that, that are not supportive of what they find to be native and important to them, then that's going to present a barrier. Limited English proficiency, of course, is a concern in that if I am not able to communicate with my provider, then there's chances that they may not be able to communicate with me very well. And without question, of course, that's going to provide a huge challenge to receiving health care. Whether or not an African immigrant has insurance, has employment, if they're able to have a job where they have insurance provided, can they afford it? And if they can afford it, can they take the time, or maybe there are multiple jobs, to engage in the health care that they need? And then, as I've spoken, and as was spoken very well in the video, cultural differences, the challenges that may exist when it comes to seeking care and how I expect care to be received as an African immigrant versus how it's delivered can also be a barrier. These slides speak to some perceptions of disease to further illustrate some barriers and challenges that African immigrants may face as they come here to the U.S. and seek health care. For instance, Ethiopia, the second largest or second most populous country in Africa, and is home to the third largest number of people living with HIV and AIDS, yet only a small percentage of the population, according to the data presented here, believe that HIV and AIDS treatment can actually help someone live a longer life. Why those beliefs exist are not clear, but the fact that only less than 6% of people believe that treatment is going to be an effective method of care, if someone's coming with those ideas and those perceptions to this country or to any other part of the world, then that's going to affect their health-seeking behavior. In Kenya, it's often believed that supernatural forces are something that influence or cause an illness, cause a disease. And that's something that is also a common belief in Nigeria as well, and in other parts of the African continent, that diseases are something that aren't necessarily biologically induced, but that are caused by exterior or supernatural forces. In Cameroon, a popular belief, and then as well as other West African countries, alternative medicine is just as integral, if perhaps not more so, as traditional Western medicine. I love this quote here. It says, "I think that biomedicine and traditional medicine are two sides of the same coin. They serve the same purpose by treating my diabetes. I cannot stop one to favor the other. It will mean that I'm committing suicide." And so this patient believes that one treatment isn't better than another. In fact, they might even have a bias towards the alternative treatments that they're familiar with, that perhaps they were raised with and that have been passed down over generations. And so to recognize that people are coming to the table with their ideologies, with their beliefs, with things that are important to them, that's definitely going to influence their health-seeking behavior and the treatments that they are willing or unwilling to adhere to. Now, thinking of barriers to care that are presented to those providers of African immigrant patients, many of these that are listed here, and of course they're not exhaustive by any means, but many of them are similar. Similar to the quote that I just read, they're kind of the same side, two different sides of the same coin, and that the perspective of the provider is different along these barriers and challenges. As you may recall, I noted that being a limited English proficient is going to provide a challenge for the African immigrant patient, and similarly, that's going to cause a barrier of communication for the provider. If they can't adequately express themselves, what their concerns are, and how to address them, then that patient is going to walk away with the missing gaps in their treatment of care. And so hopefully, if they have an interpreter that is speaking a language that is native to that African patient, that will help eliminate those challenges. But it definitely can cause a barrier. Similarly, if my patient, as a provider of care to an African immigrant, does not have employment or doesn't have insurance, how can they come and see me? Will they come and see me regularly? Do they have the means and the money to provide, to seek the treatment, to see me regularly, to receive the medications that I'm prescribing? From a cultural perspective, do I understand the expectation that my African immigrant patient has of the healthcare system, of what I can offer them and what I can do to assist them in achieving health and wellness? As far as religious beliefs, do I understand the religious beliefs and how important that is to my African immigrant patient? Am I willing to negotiate and work with my patient to help them achieve optimal care? Regarding immigrant status, what are my feelings about treating someone whose papers may not be documented, who may not have the correct status? Do I still want to treat them? Do I have biases against that? And if I don't have biases against that, what can I provide as far as my institution or organization is supportive of me doing for my African immigrant patients? And then what are the resources or supports that I have available to me to direct my African patients? One great example that we often use with our Project Vita is the idea that there's a local clinic here that does great work, provides very competent and thorough care for HIV and AIDS patients, regardless of their backgrounds and their countries of origin. But unfortunately, from the perspective of an African immigrant, it is also a clinic that is highly patronized by a homosexual population. And so with the stigma, going back to barriers mentioned for African immigrants, how does that keep me from accessing great care, but that from a stigma perspective or from my perspective of health-seeking behavior isn't necessarily care that I think is for me? And so as a provider of care, how do I know and tap into the right resources that my African immigrant patients will identify with and will seek and will pursue? Speaking of the provider and patient interaction and relationship, I think I really appreciate this slide because it really speaks to the barriers that are on both sides that we discussed, both from the provider perspective as well as from the patient perspective, and how the influences of culture, past experiences, and a number of other things all play into the ideas we have and how we actually perceive the treatment, the talk, the conversation that is being had, and ultimately drives my behavior. And so it's easy to think sometimes that in this moment, as I'm having this conversation, as I'm interacting with my provider, the decisions are made based on the here and now, the facts that are presented. But as providers, and both as patients, I think it's important to recognize the influence that everything before this current encounter, our culture, our past experiences, our knowledge and education, all of those things impact how we will receive care, how we will deliver care. And so something for us to consider as providers, and also something for us to consider that our African immigrant patients are considering in their interactions with us. Which brings me to something of a million-dollar question. So with these barriers that we discussed, these influences and these backgrounds and considerations that influence our behavior, how do we address the unique challenges that are associated with improving African immigrant health? Because as we discussed, from both a provider perspective and a patient perspective, there are unique challenges, unique nuances that need to be addressed that can't be ignored if we truly want to deliver culturally competent care to this population. Brings me to my next polling question. So how do we address the unique challenges associated with improving African immigrant health? Is cultural competency necessary, patient-centered approaches, partnerships with other community organizations, structural interventions, or some combination of all four of these methods? And as we're slowly trickling down, it seems as though the unanimous decision is indeed all of the above. I agree. Through a collaboration of different methods and different approaches and different partnerships, that's truly how we're going to move the needle forward and move progress forward to achieve optimal care for our African immigrants patients. It's through partnerships, it's through collaboration, through many approaches that we will be able to truly improve the health of a people one person at a time. It won't happen overnight, but it will happen with strategic planning and passion, as both my colleagues expressed. And all you who are participating on this webinar, I'm sure, have as well, a passion and a desire to see improved health and wellness for our African immigrant patients and be the means of moving the needle forward on seeing improved health outcomes. With that, I'll leave my contact information here and turn the floor back over to our moderators for questions. Thank you.
In closing, we would like to inform you about the National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day, NIRA Day. As noted by the information shared by the presenters, African immigrants constitute a highly diverse and rapidly growing group in the United States that is disproportionately impacted by HIV/AIDS and Hepatitis B. Hence, a group of individuals and community-based organizations convened to establish September 9th as National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day, NIRA Day. Similar to other HIV/AIDS awareness days, the purpose of NIRA Day is to bring national and local attention to the HIV and viral hepatitis needs of African immigrants living in the U.S. in a culturally and linguistically appropriate manner. The creation of a National Awareness Day will also support the eradication of other epidemics fueling or related to HIV disparities among African immigrants, including tuberculosis, substance use, and mental health. For more information about NIRA Day, please go to www.mac-boston.org. Also, each organization or individual can join the initiative and host an event on September 9th. Thank you to all the presenters. Now we will answer the questions that were posed during the webinar through the chat feature.
Thank you again to the presenters and the participants. We do have two questions, and I will start with, what can participants do to influence CDC to collect HIV by person's place of birth? And Roxanne, I'll let you answer that question.
That is actually a very challenging question, and I'm not sure what the best answer is to it. I do know that the White House is now calling for recommendations and comments on the National HIV/AIDS strategy, and one of the recommendations that I actually submitted was to collect and present data on region or country of origin for people who are reported with HIV in the U.S. And so that would be at least one step to knowing more and having better data. Additionally, I think people can work with their local health departments, and I think this is going to have to be sort of a grassroots movement that starts at the local level, which it already has in many places, to put more pressure on their colleagues at the CDC to start looking at these data and making the changes necessary to collect country of origin more consistently.
Thank you very much. Our last question is, what are the reasons for the differences in proportion of HIV cases reporting MSM between U.S. and African countries? Is it truly a heterosexual disease in Africa, or do cultural views on homosexuality potentially skew reported risk factors? Roxanne, I'll let you start, and if any of the other presenters would like to add, they can also do so.
Okay. I think that my first thought on this answer is that what we know about the ratio of male to female cases in African immigrants is very similar to what we see in African countries where there's a generalized HIV epidemic and most of the transmission is happening through heterosexual sex. So here in the U.S., in the U.S.-born population, we find many, many more men infected with HIV than women because they're acquiring HIV from each other, and the epidemic is concentrated in men who have sex with men. But in areas that have a generalized epidemic and there's transmission between men and women, then you're more likely to see equivalent proportions of people in each gender infected, or I guess people who are infected tend to be men and women in equal numbers. And while we see a few more women actually in the African immigrant population diagnosed with HIV here, I think that speaks to the fact that there is mostly heterosexual contact. But again, I definitely don't rule out men having sex with men, because I know from talking to people that there are men who acquire HIV through MSM contact, and I don't want to discount that at all.
Thank you. Do any of the other speakers want to comment? I can add to Roxanne's response. I think from a perspective of better understanding the African community, I think that we need to look at how sexuality and sexual identity is truly understood within the population. I would challenge us that we continue to hear that homophobia is higher within foreign-born black populations than in other populations such as U.S.-born populations, but I think that we need to further research within the African context. How do we foresee, or how do we see or understand sexuality and sexual identity? How do we experience it? Too often, Western ideologies are dictating the understandings of Africans, which further sort of perpetuates myths and things of that nature. So I would definitely propose that we start looking at doing more social and cultural research that gets to further understandings in terms of an African context around sex and sexuality and sexual identity. I would also say that compared to African women, African immigrant men are less likely to engage in screening services, HIV and hepatitis B, and so that might impact some of our current conclusions or our current data that we have. So again, thank you presenters and participants. If you have any additional questions, or if you feel that your question wasn't fully answered, please let us know via email, and we will definitely get back to you.
Thank you for participating in this webinar on epidemiology of HIV, AIDS, and hepatitis B among African immigrants, current status, barriers, and challenges. As part of the series, we have 2 upcoming webinars. Monday, June 1st, 3 o'clock p.m. to 4:30 p.m. Eastern, Improving HIV Prevention, Screening, and Clinical Care for African Immigrants. Monday, June 15th, 3 o'clock p.m. to 4:30 p.m. Eastern, Improving Hepatitis B Prevention, Screening, and clinical care for African immigrants. Please register on www.neatec.org. If you have any questions, please contact Chioma Anaji. Contact information is provided. Immediately after we close the webinar, you will receive the evaluation. Please keep your web browser open and the evaluation will appear immediately. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Attendees who are requesting nursing and social worker continuing education units are required to complete an evaluation form. A certificate will be emailed and/or mailed to participants within 4 weeks. Thank you again.